Ora, bem-vindos de novo. Seguimos para a última parte desta conferência com a oradora Natalie Berry, conselheira sénior do diretor executivo do The King's Fund, para nos falar da sua experiência no âmbito das políticas de saúde e de cuidados de saúde, os desafios de financiamento, os cuidados integrados e a implementação de grandes reformas como o Plano de Saúde há 10 anos. Natalie, please. Welcome.
Okay. Bom dia, or boa tarde. Obrigada. I will be speaking in English today. Thank you very much for listening to me in English. I'm just wondering how I get my slides up on the screen. Just wait 1 minute. I am one of the, I think, sadly rare few British people who does speak a number of other languages other than English. Sadly, I'm not very confident in Portuguese, so thank you for your patience in listening to me in English today. So, there's a saying that plans don't deliver change, people do. And of course, that is true. But if there are two things we know about the NHS in England, sorry, there we go. Let's go back. Where's it gone? Sorry, go back to the start. There we go. If there's two things we know about the NHS in England, it's that it's full of people, but it's also full of plans. So around 1.6 million people have contact with NHS services every day in England alone. Around 1.5 million people are employed by the NHS, and 59 million citizens rely on its protection from the universal coverage it presents. At the same time, we have a new 10-year plan for the decade, a new 3-year medium-term planning guidance, and this whole raft of service-level plans, condition-level plans, guidance and frameworks that are either landing now or due to follow. So, plans don't deliver change, people do, but here's the footnote to that. Plans can make all the difference if they're effective. They can provide clarity of vision, of purpose, and of goals. And they can provide the leadership and the policy context that enable those people to act. So we can't give plans a free pass. We do need to scrutinise them, we need to challenge them. And there are some tests of how the ambitions in the plans could move into action. And that's what I'm hoping to explore with you today. So I'm Natalie Berry, I'm Senior Advisor to the Chief Executive at the King's Fund. I have a background in health policy. I've mainly worked in the civil service in the Department of Health and Social Care for over a decade in England, but also I worked at the Health Foundation along the way, which is another research organisation and think tank in England, and in a social enterprise supporting leaders out in the NHS and in local government with collaboration across systems. At the King's Fund, my role is leading on strategy and major priority projects and also on cross-system policy, so analysing things like the 10-year plan. And at the King's Fund, we're an independent charity. We're focused on improving people's health. We do that through research, we do that through leadership development, and we convene people to drive change. But one of the main things we could do is help people to navigate the complexity of a complex health and care landscape, and so reflect on what that means and learn lessons from that too. So that's what I'm planning to do today. So politics and policy in the health context in the UK and in England are very much interlinked. So let's just rewind to last year's general election when a new government took up office. So on day one, the new government and the new health minister came in with a bold and emotive message that the NHS was broken. They then commissioned a rapid diagnosis of the problem from Lord Darzi, who is an eminent surgeon, a former health minister in the last Labour government, and a well-respected health and care leader. That was published about 2 months later. They held a listening exercise with staff and the public, which is cited as being the biggest conversation about health. basically talking about what people want from the health service in the next decade. And a year on, in July this year, they published their treatment plan, a 10-year plan for the NHS in England. All of this was launched under an existential message, a need for reform in order to save the NHS. Now, it's quite bold that a government would start their term in office with such a bold and challenging message. It provided a platform for reform to turn the health service around. But this existential theme does continue into the plan itself and is continuing into the subsequent documents that are following. Now, Lord Darcy's review was a reasonably rapid analysis, but it was authoritative and it drew on a lot of the established data and evidence. So he concluded that the NHS is in serious trouble, but the first step to rebuilding it is to be completely honest with the public about where it stands. He said the NHS is in critical condition, but its vital signs are strong. So it was a sobering articulation of what people have been telling us for a while, that services were stretched to breaking point and that people were losing trust in the NHS being there where they needed it. So it provided the government with a case for reform. He made an assessment about where money could have been better spent, about the workforce morale and conditions, and about the impact of frequent restructures and confused lines of accountability. But perhaps most interestingly and pertinently when we think about health and what we know contributes to our health and inequalities in health, he made a much bigger statement. He said the state of the NHS is not due entirely to what has happened within the health service. The health of the nation has deteriorated, and that impacts its performance. He said the NHS has faced rising demand for healthcare from a society in distress. So that points to the need for a much broader, more comprehensive approach to tackling a population health challenge, a health in all policies approach, a mission for health. The government paused to listen. They engaged huge numbers of staff, patients and the public. We at the King's Fund saw this as a huge opportunity, honest conversations with the public and staff and generate solutions together. But the key test of any engagement is whether it's a genuine dialogue. How does it show up in the policies that follow, and how does it continue to live on so that the change itself is led by those people too? But why all of this existential narrative and why this big conversation? It's helpful just to look a bit deeper into the context for this plan. So first, look at our overall population health, which, as Darcy said, has deteriorated. In England, our overall population health is in decline. Healthy life expectancy has stalled, and for those born today is now below the retirement age. Trends were stagnating or in decline prior to the COVID pandemic and have not recovered since. Mortality rates in the UK are worse than our peer countries, and working age adults are the group currently with high and rising levels of morbidity and economic inactivity due to ill health. And health inequalities with all of this are stark. People in deprived areas live nearly 20 years less in good health than those in richer areas. These inequalities show up in unequal access and quality of care, and they're shaped by broader social factors like housing, like education and employment. So the reality of our current society in distress, as Darcy put it, is our fundamental challenge. Growing levels of poverty, of deprivation, all loom large in our population health. And public satisfaction with the NHS is at an all-time low. The top concerns referenced by the public include GP, so primary care access, waits for emergency departments, and hospital waiting times. Now, there's a constitution for the NHS in England which sets out a number of standards and targets, and many of these have not been consistently met for multiple years, so that largely these are standards around access and diagnosis. But that is also where a lot of the leadership attention goes. So this government has had a laser focus on elective recovery, so elective care, planned care, non-emergency care. The government's prioritising this recovery in particular, and they have a target that 92% of patients will be treated within 18 weeks of referral to treatment by 2029. Now, the pink line on this chart is the simple stepped recovery it would take to meet that goal. So whether or not it is met, what I think it shows is that that will take a huge amount of resource and attention to try and get there. And we have a workforce facing shortages, high levels of burnout are widespread, vacancy rates remain high, and we've got industrial action, and that's reflecting the deep strain in the system. Just before the plan launched, we had a spending review, and that provided the funding envelope. Now, health received a huge share of the public finances. Other public services look at health with envy, but many of the determinants of our health sit in those areas, so housing, clean air, travel, for example. But the new funding deal is still below long-term averages, so it's very positive, but it won't necessarily feel like a huge bonanza for health and care leaders. And that's what's really coming through to us when we meet leaders, that they are still making some pretty tough choices. And just to put this in the international context, the UK health spending as a share of GDP is comparable to peer countries, just above the OECD peer country average in 2023. But our trajectory of health spending compared to our peers is one of the justifications that the government cites in the 10-year plan for a focus on productivity, because they say that our share of GDP on health has grown over the past decade, but outcomes and productivity have declined. And the longer-term financial outlook confirms the nature of the task. So without addressing both productivity and prevention, so supply and demand side factors, health spending is projected to become unsustainable, and that's based on the independent projections of the Office of Budget Responsibility. So improving the health of the population would not only reduce healthcare demand, but also bring wider fiscal benefits through higher tax revenues and lower welfare costs, is what they say. And then finally, what is, as telling us what is on the government's priority list, is what hasn't made it quite so far up the agenda. Social care reform, we heard earlier, is urgent. So the current model for social care, long-term care, is fragmented, underfunding, and leads to ration care. And it's a very, very different model to the NHS in its funding nature and its delivery. But too often it's only discussed in relation to the NHS, so in terms of getting people out of hospitals, rather than in its own right for what it brings to people's dignity, independence, and for sustainability of the system. Yet action there just isn't seen as urgent. So there was a lot of anticipation around the 10-year plan, and rightly so. It landed in a moment of consensus about the challenges facing the NHS and the need for change. And whilst the review of data that I've just gone through is quite depressing, I'd argue that there could be a moment of hope in having a clear problem. We don't need to argue about the problem anymore. We know it, we understand it, we name it. We can then get on with addressing it. So the plan was published in July. It's ambitious, it's wide-ranging, it's 168 pages long if you want to read it. Much of it feels quite familiar. It builds on past reform efforts. The real challenge isn't really in new ideas, it's in the delivery. How to make change happen at scale and at pace. So we know why to do it. We know broadly what we need to do. People wanted clarity from this plan on how to make that change happen, particularly successfully over a decade in a system that has quite a normalised culture of short-termism, a constant of change, and pretty low kind of planning and funding certainty over the medium to long term. So what did this plan say? Let's have a look. So the plan centres around three big shifts, going from hospital to community, from analogue to digital, and from sickness to prevention. There are these three shifts, and they're supported by a raft of interventions and supporting goals around quality, around patient voice and choice, and around the system wiring. It's a mix of market-driven models associated with the early 2000s and then some more collaborative, integrated system, population health-based models associated with the last few years and that David was referring to earlier. If you look across it, it can be quite hard in all of those 168 pages to find one clear organising principle. But I think the theme that stands out the most in the original plan is the analog to digital shift. So technology is expected to change the way people access and interact with services, to take over many administrative tasks to free up staff time, and even prevent ill health occurring by allowing for predictive and personalised care based on genetic sequencing. They have made 5 big bets for innovation: data, AI, artificial intelligence, genomics, wearable technologies, and robotics. These are undoubtedly transformative technologies which could drive a new model of care through aligning research, investment, and innovation. Coming a close second for the key organising principle, and probably taking much of the leadership attention since the plan so far, is the shift from hospital to community. So it talks about a new neighbourhood health service, sitting at the centre of a new offer to the public of how we access care in the future. A neighbourhood health centre in every community, and new contracts to support different provider models. So it's the shift from treatment to prevention where it feels like the government hasn't been quite as bold or radical as we might have hoped. So the plan does put a helpful renewed focus on secondary prevention, which is preventing decline in illness once it's there. But there is still further to go on ambitions for a healthier nation and primary prevention, so tackling the risk factors and the environmental factors that shape our health. And as we'll explore, when the existential threat is only framed around demand reduction on the health service, it misses a broader point about health, about inequality, about poverty. So a piecemeal approach isn't enough in that context. So that's why we and many others were sorry to see that this shift was more evolution rather than revolution. Alongside those 3 shifts, the plan and the subsequent documents that are following do say a lot about how the system needs to work for patients, what it means for staff and leaders, and it describes the system architecture and the financial framework that will help enable the vision. In terms of patients, there's a huge focus on patient choice and experience driving up performance, even at an individual level, with payments linked to feedback from patients. The plan acknowledges the immense pressure facing staff and leaders. It includes a range of reforms aimed at improving culture and care delivery. It then points to a further, more detailed workforce plan, which is one of the plans which will follow. But it's clear from the narrative that the focus is on technology, reducing the reliance on staffing levels. So we're expecting that any forthcoming workforce plan won't see huge increases in staffing numbers or commitments for that we might have seen in previous documents. The plan signals a change in how the system will be structured and governed, aiming for a slimmed-down centre at a national level by merging NHS England, a huge organisation, back into the Department of Health and Social Care, essentially reversing the reforms of the last decade. And it talks about providers gaining more autonomy, framed, though, as earned autonomy, so as in when performance and accountability measures have been met. And there's a renewed focus on strategic commissioning and an attempt in doing so to clarify different levels of leadership. In terms of the finances, there is a welcome attempt to try and hardwire some of these shifts in through the financial framework. So there's a clear aspiration of rewarding high-quality care, so dismantling some block contracts and trying to link contracting closer to quality and activity. There is a plan, the plan tackles a question of fairness in funding by rebalancing it, partly by need, so in primary care towards kind of higher levels of deprivation, but also by sector. So there's a decisive commitment to shift funding from the hospital sector to community and over the next 3 to 4 years as this neighbourhood health service grows. And it attempts to introduce a much more strategic approach to financial planning, so multi-year budgets and plans to try and increase stability, focus, and a renewed and welcome focus on capital, so infrastructure funding, and a commitment to try not to have the temptation to raid that essentially for day-to-day spending. The plan sets a bold ambition to end deficit support and get all organisations back to financial balance by 2030. That's quite a tall order in today's financially pressured environment where a lot of leaders are already making tough choices that impact patients. But it's clear that from the original plan and definitely the more recent planning guidance, that productivity and financial balance are essentially the fourth big shift. They probably always really were in terms of the nature of what's going on and what's been happening in the last year or so. So they talk of ending a habit at the centre of rewarding organisations in deficit with additional funding. So, if that's the ambition, how can this move into action? So before the plan was launched, I wrote about 5 key tests that might see whether this would actually be actually drive some change in practice. So does it hardwire the shifts in with funding and resources moving? Are people at the heart of this policy design? Is there humanity there? Is it relational? Does it tackle the trade-offs? Is it actually a long-term plan? Do we have confidence to stick with it? And does it inspire hope? So what's the assessment based on those tests? Well, I'd say the shift to neighbourhood health is one of the most significant shifts in the transformation agenda. It's where many are and will focus their energy. But clarity of purpose about this is essential. So this term is used in many different ways, and without a shared understanding, we do risk sort of leaping from to form before function. So broadly, you can think about neighbourhood health in 3 ways. The first, as a model of care delivery for complex needs. So multidisciplinary teams coming together, whether that be virtually or in a physical location, to organise around people's care. It can be as a way for cross-sector services to work on determinants of health together, so housing and health, or potentially the health service providers with voluntary sector, civil society. And it can be a community-led approach that's shaped by local people, designing services around local needs. Ultimately, with those bottom 2 involved, neighbourhood health offers quite a powerful opportunity to reshape care around people and communities. The 10-year plan, or at least the subsequent guidance, appeared to focus on the top one of these at the moment. That might be as a powerful demonstrator to build from. The framing is largely about those facing the highest acuity needs, health needs, and aiming to improve their quality of life, but aiming to reduce avoidable hospital use. But this shift does need to go beyond relieving hospital pressure. That risks too narrow a focus. The real prize could be in driving ahead with those broader opportunities to make sure that services are community-led, not just community-based. But to make this shift real, we must shift resources, financial, people, towards those communities. So the King's Fund's work on this area over many years has shown that for too long, hospitals dominated investment and visibility of data too. So you can see from this chart that most daily activity in the NHS happens in general practice, primary care, not in hospitals. Yet there's an absence of data, funding, and attention. So we refer to this in our work as a cycle of invisibility. So in a test of hardwiring, the commitment to shift funding and to focus on neighbourhood health centres is welcome, but it will require different data and measurement too, so that we can direct people's attention as well as resource, leadership attention in particular. It requires new commissioning models, shared budgets, and genuine collaboration across sectors. And for example, it can be helpful to be clear that co-location in neighbourhood health centres isn't enough on its own right. So it's a great tool, it's very powerful, but past analysis from the King's Fund about a decade ago showed that simply putting services in the same building doesn't guarantee integrated care. Cultural, operational changes like new care pathways and team models of working are essential too. And we need to be honest about the trade-offs, so back to those 5 tests. It won't necessarily save money in the short term. It will need upfront investment in the workforce, in infrastructure and technology, and depending on how you're measuring success, when the cost is measured, could drive how this is viewed. So England already has a reasonably low hospital bed base, so it's unlikely that huge amounts of money would be released by acute hospital closures, even if activity does move across. And we need to face off to some big, quite tricky strategic trade-offs, like do we prioritise investment in community infrastructure, like neighbourhood health centres, or do we continue to maintain our ageing hospital estate? And avoiding those sorts of decisions aren't neutral or a kindness. It risks normalising poor building conditions in both if we duck that sort of decision. And for the estates, in our today's context, it's very likely we'll be making better use of what we have, rather than building lots and lots of new. And that is a very pragmatic step, and there's huge opportunity, there's huge underutilised estate, but of course it's going to be variable depending on where you are, and so that in itself is a trade-off too. Now, on the digital shift is probably a good example of where people comes into policy making. So this is where the relational and the technical can intersect. So the ambition to free up staff time to improve access and harness innovation like AI and predictive medicine is absolutely right. We also need to get the basics right, and that's what staff and patients have been telling us, is fix the fundamentals. AI scribes won't transform productivity if staff still spend half an hour each morning trying to log on to an outdated IT system. So to truly drive digital transformation, we need to invest in people as well as technology. So the plan's reliance on digital tools to ease workforce pressures does need to be matched by a bit of realism that tech alone won't solve burnout, staffing gaps. And we need to acknowledge the impact of change fatigue on the workforce. So after years of top-down reform and kind of post-pandemic strain, we need to rebuild trust through visible leadership and open communication, and not just try and impose change. And as I said, the prevention shift is where confidence in the plan for the long haul potentially is weakest at present time. So in a system that's stretched by hospital and acute demand and short-term pressures, prevention will always risk being sidelined unless we deliberately prioritise it. Scotland offers a useful contrast there. They've made much more progress towards a coherent population health vision for their nation, but still wanting to go now into implementation. England had the opportunity to do this with the health mission that this government signalled when they first came into office, but it's been watered down, possibly gone missing. So back to the existential point, this is a huge risk, needs urgent attention. We currently say the 10-year plan is a plan for the NHS, but not a plan for health. So there are competing sort of theories of change across the plan at the moment about how to make it happen. There's a sort of push for national modern service frameworks, condition-specific plans, quite programmatic from the top. And there's also a huge commitment to devolution and to locally led solutions. It's not always clear exactly which one's going to work where, so that's something that's really helpful to clarify sooner rather than later. And as I mentioned, the plan contains some competing incentive models, some market-led, some collaborative, and international evidence shows that it's really important to kind of stick with one, so there's coherence and clarity. And when to make change stick, we do need long-term commitment, but we also need to hold our nerve, because transformation will take some time. It's complex. We've heard that today. It involves a lot of complexity and coordination, and The very structures that support that are currently going through a lot of change themselves. So we can't keep expecting change in huge complexity, wondering why it doesn't materialise immediately and then immediately changing it again. So we need to be able to sort of tolerate some emergence. So at this particular moment, this really pivotal moment between a plan and implementation, coherence and confidence feel like they are particularly key. So bridging between the two. And we could potentially use all these forthcoming plans to support with that. And we'd argue we need a clear organising principle, and that we'd say it needs to be wider health, not just reductions in hospital activity or waiting times. So the NHS's existential challenges need to be seen in the wider context of population health, of society's deep needs right now, and then cross-government action to tackle this. But the NHS in England is a very politically driven system. How it's led is closely tied to this. With each new health minister comes a new plan, a new approach, and often a whole new change in direction. At the start of this new government's term, there was talk of long-term reform and holding nerve through big, tricky changes. By the time the plan was published only a year later, their political context had already shifted, domestically and geopolitically, which has reintroduced a sense of urgency and some short-term mindset. So that will show up in how change is led, with access targets likely to dominate the agenda. But we need to lead from a place of hope, not of fear. The vision in this plan is strong. It's full of huge possibility, huge potential for massive change. Many of this is building on work that's been underway for a long time, with leaders adapting and innovating and making change happen. So it's not about reinventing that. With that foundation, the opportunity is to scale what works. And if it is fully realised, this plan could transform care in England by 2035 into a health service that's digitally enabled, rooted in communities, shifting towards prevention. I think that's a future that the public, that patients and that staff would welcome. So yes, it's ambitious. Yes, the trade-offs are implied rather than stated. But the consensus for the fundamentals is there. So even if we're now relying on a raft of plans and frameworks, and that isn't necessarily perfect, they can be tools to clarify, to embed, and to navigate complexity. So we return to where we began. Plans can enable change if they bring stability and if they help us hold our nerve. So to implement this successfully, we could use the clarity on the problem as a springboard for long-term reform. To do that, we need some coherence, and we could use these coming plans to really help provide some clarity and tie all these various great but disparate ideas together so it's nice and clear and not to add levels of complexity of interpretation. And we could orientate this towards a much bigger mission of health. But fundamentally, we need to lead all this change with compassion. So you can't performance manage your way out of burnout or rebuild public trust by hitting access targets alone. So the bigger leadership culture is crucial. Those leading change being genuinely trusted to do so, rhetoric matching reality, and these further detailed plans being used to clarify, to cohere, to inspire, rather than to transact or to curtail. And if we get this right, if the plan is realised in full, the NHS, the health of our nation, would be on a much stronger footing. So your conference the last couple of days has all been about value, what we value in health. That often shows up in how our systems are organised, what we measure, and how we act. So hopefully really help this exploration of what's currently happening in England right now, the promises it has, but also some of the challenges we're facing could be useful to you as a way of closing your conference, so that you as leaders can reflect on where this aligns with your work, with what's happening in your systems, what's going on for you in your experience, and hopefully inspire a bit of curiosity to think about where you have agency in your own work to navigate some of the themes that we've discovered and explored today. So thank you. Obrigada.
Thank you, Natalie, for your diagnosis of the diagnosis and the treatment. One of the old and growing challenges remains the human resources. You mentioned tech, obviously, but you also highlighted that tech is not going to invalidate the need of the human resources. So the lack of them, what solutions do you find in the plan? If you find anything in the plan, as you know, UK is recruiting outside, in Portugal as well. So,
Indeed. So, absolutely, really good question. I mean, as I said, there's a huge emphasis on technology as maybe a reason or a solution to not necessarily need to focus always on recruiting more people. People will always be at the heart of healthcare, and it's a human system. So tech can enable those people, but we can't rely on that alone. And as I explored, with the current sort of staffing levels, but also levels of morale and burnout, we need to just be very careful not to be jumping to that as a kind of silver bullet solution immediately. We are facing some vacancies and shortages, and we're having some challenges with industrial action too. We have been traditionally, recently, solving that with international recruitment. This government now is facing a lot of other political challenges, and so there's a shift away from some of that as well. So that will add further challenge and dynamic to the system. When I talked about social care, they're further down that line. So again, there's been a reliance on needing to recruit internationally because our kind of domestic workforce hasn't been there. We've had issues with sort of fair pay and so on. And again, curtailing some of those kind of arrangements is now showing up quite clearly in the rationing of care in social care and some of the big changes they're facing too. So, in terms of solutions, I think there is a workforce plan due to come. We're really looking to that, not only to kind of clarify on numbers and projections, but also around this kind of cultural shift that's needed in the leadership, in the way people are empowered, because a lot of this change could be led and will be led and is being led by the workforce and by leaders locally. I think the burnout, a lot of the burnout's coming from essentially this change fatigue, this kind of, it's another top-down reorganisation. What are we doing next? And so if we were to truly shift to what's been talked around some of the devolution and the local and place-based working, harnessing the partnerships across local systems and local partners, civil society, voluntary sector that we've talked about today, that could be part of the solution. The NHS doesn't need to look at it on their own.
Yeah, we have our own plan. Do you know that?
Yeah, so I've been looking at some of the parallels.
Yeah. Do you like it? It's called Emergency and Transformation in Health. Yeah. It was presented last year. Yeah. Like in 60 days, we are going to change everything. Well, as you imagine, more than 60 days has passed and we don't know even the direction. This is important for us, as you said, because of the direction. We have a focus and we have a goal.
Yes.
We don't, sorry. So, 6 months ago, you have, in UK, you have established the NHS executive direction. Why do you think that didn't work? And what you expect will be the model of organisation considering this?
Yeah, so this has come up a few times today, hasn't it? That when we talk about collaboration, integration, which has been a focus for the NHS for a long time, much like the rest of the vision, a clear vision and a direction is fundamental and the kind of clear purpose. We also then need a lot, so the evidence around collaboration, for example, clear vision, purpose, fundamental, clear roles and responsibilities are fundamental. There's then also a wave of relational factors, leadership, relationships that make some of this change happen. Trust, generosity between people, leaders being kind of able to actively span boundaries and work together. And then there's a bunch of kind of system wiring, incentives, measurement that can support it. And what we tend to have a default to do is set the vision and immediately go to the structures and the measurement and the data and kind of miss out that entire middle bit where that is crucial. And actually what we've seen is that where change really has been led and is happening, it's all often been people people's relationships, people's leadership that's made that happen, sometimes despite the financial framework not working in their favour, the shared budgets, etc. They kind of find that way around it. So I think missing that middle, that kind of relational side of all of this and assuming that the structures alone will drive change is where we often have
So
the gap.
you're going to shift from a centralized position to a local one.
So that's the intention.
Okay.
It's been the intention, I think, in subsequent plans, many plans over the years. The NHS in England is very nationally driven, and we saw the reforms of the kind of 2012 Act were all about let's shift politics away from the NHS, let's devolve the responsibility. And we saw that despite the structures going in, the behaviours remained of essentially that feeling that accountability still sits with the politicians and ministers because it's so ingrained in kind of public consciousness and what people are sort of perceived to be voting on. And so we're now back to sort of pulling some of those functions back into the centre at the same time as saying we want to support more local freedom and devolution. That's where we need the clarity of on which things are being nationally directed and on which are being locally led. Clearly, the majority, ideally, would be, especially in a neighbourhood health service and more population health focus, would be at a scale that is local, it's community-led, it's at that level, and you need your national tier to be enabling that with legislation where needed on some public health measures and financial frameworks, but otherwise being enabling. We are still trying to do both things, and that's where the conflict arises because essentially there's a sort of looking to the centre for more plans because the centre keep giving more plans.
Yeah, hoping that all stars aligned,
Yes.
mainly, isn't it?
Yeah.
So we have a lot of similarities
Yeah.
since the beginning of our NHS, so let's keep our radars on. Thank you so much
Thank
for your
you.
presentation.
Thank you.
Thank you. We can go. Yeah, thank you.